Access of the pulmonary arteries is a standard technique that is used for multiple diagnostic and therapeutic purposes. We will discuss the tips and tricks for accessing the pulmonary arteries in this section. This presentation will discuss the techniques for advancement of catheters through the right heart into the pulmonary arteries. We will discuss further advancement of wires and catheters through anatomical structures in order to place diagnostic and therapeutic catheters in subsegmental locations. Finally, we will discuss the tips for angiography to perform an adequate visualization of the intended structures. Access into the pulmonary arteries can be obtained from several superior locations, such as the internal jugular veins, subclavian veins, and basilic veins. Access from the lower extremities is usually from the common femoral veins. We will only be discussing access from the common femoral veins. Some of the tools used to evaluate the pulmonary arteries include angiographic catheters, most of which are 5 or 6 French. These can be pigtail or angiographic catheters. Pigtail catheters can be either straight or angled. Angiographic catheters may include Judkin's Right or multipurpose catheters to access the pulmonary arteries. Balloon tip catheters may also be used. The Swan-Ganz catheter is often used for right heart catheterization. We frequently use wedge catheters or Berman catheters at our institution. Guide wires are also important in accessing the pulmonary arteries and are used to direct and exchange catheters. The wire typically used in our institution is an exchange length 035 hydrophilic coated wire. As we can see in the left image, the pigtail catheter is advanced through the inferior vena cava up into the right atrium. The pigtail is rotated anteriorly within the right atrium of the heart. The image on the right shows the catheter being rotated in a clockwise direction, approximately 45 degrees from the anterior aspect of the right atrium toward the right ventricle. With the pigtail catheter low in the right atrium, the pigtail is directed toward the right ventricle. The wire is then advanced into the right ventricle, and then the catheter is advanced over the wire into the right ventricle. With the wire pulled back into the pigtail catheter and the pigtail in the right ventricle, clockwise rotation of the pigtail and advancement will direct the pigtail up into the right ventricular outflow tract and allow advancement into the main pulmonary artery. With the pigtail just above the pulmonic valve and directed toward the right pulmonary artery, the wire can be advanced into the right pulmonary artery. The catheter is advanced forward while simultaneously pulling back on the wire. A slight push-pull will reform the loop. For pulmonary angiography, care must be taken prior to the injection of contrast through the pigtail catheter so the catheter is not positioned too distally in the pulmonary artery. If the pigtail catheter is placed too distally, the right upper lobe may not be filled with contrast and may not be visualized. It is important to position the pigtail catheter in a mid to proximal position within the pulmonary artery so that the major branches can be visualized. As seen in the left diagram, the left pulmonary artery is a direct trajectory off the main pulmonary artery. Therefore, catheters are more likely to be first advanced into the left pulmonary artery. At our institution, we like to start our angiogram with the pigtail catheter in the right pulmonary artery. After the angiogram, we simply pull the pigtail back into the main pulmonary artery, rotate, and advance the catheter where it typically goes into the left pulmonary artery, allowing us to perform our selective angiogram. This is how long the access takes in real time. Advance the wire and catheter into the right ventricle. Push-pull, rotate up into the main pulmonary artery. From here, push-pull to advance into the right pulmonary artery. Now we image the right pulmonary artery. Pull back, push, and image the left pulmonary artery. This entire procedure is 11 seconds in fluoro time. Balloon tip catheters can be useful in situations when there are problems advancing the pigtail catheter. We use an 035 6 French balloon tip catheter, which can be inflated in the IVC, advanced, and directionally located into the right atrium and ventricle following blood flow. When in the right ventricle, clockwise rotation is used to torque the catheter into the outflow tract, where it can be advanced into the pulmonary artery. If this method is unsuccessful, we will use the reverse loop technique. In this technique, the tip of the catheter is placed at the confluence of the hepatic vein and IVC, or right atrial appendage, and advanced to form a loop in the right atrium. This maneuver directs the tip of the catheter towards the tricuspid valve and allows passage into the right ventricle and into the pulmonary artery. When acquiring images, two techniques can be used. Subtraction imaging allows for high definition of the pulmonary arteries. However, there is a tendency for motion artifact to occur in patients who cannot cooperate with a breath hold. In these patients, cine acquisition is a useful technique as it does not require the patient to hold their breath. This technique also allows visualization of the arterial and venous phase and can show left ventricular size and function. As a general rule, infusion rates are determined by the anatomy of the vessel, which can be determined by small test injections of contrast. The goal of angiography is complete opacification of the pulmonary artery. If cine technique is used, continuing to image through the levo phase allows for a visualization of the pulmonary venous return. Typical infusion rates in a normal lung may be 20 to 30 milliliters for 1 second. In compromised patients where infusion must be limited, you will need to cut back on the flow rates to 10 milliliters for 1 second. Subselective pulmonary artery catheterization is an important skill to develop to help direct diagnostic imaging or therapeutic interventions to specific vessels. In the left picture, we can see that an AVM has been identified after subselection of the left lower lobe segment. The anchor technique was utilized to secure access in the subsegmental branch and to allow interventional access into the AVM. On the left image, our subselective techniques have allowed us to select out an AVM in a young stroke patient. As you can see in the right image, we then successfully occluded the AVM. As we have identified, subselective techniques are important for the identification of structural abnormalities, as well as for the identification of subsegmental emboli. Steerable catheters will help select branches that have the highest thrombus burden and allow for the placement of infusion catheters in the subselected vessels. A thorough understanding of the bronchopulmonary segments is essential if you are going to perform subselective pulmonary angiograms. You can see from the diagrams that each bronchus divides into segments and that each bronchial segment has a pulmonary artery attached to it. This understanding is important to effectively communicate the areas that have been treated to your referring physician. In conclusion, selective and subselective PA catheterization techniques are easily mastered. PA catheterization provides accurate diagnosis of anatomic anomalies and other diagnoses such as PE, and enables effective interventions including AVM treatment and catheter-based thrombolysis.